Hello and welcome to the first in our series of 6 Dementia Talks, Lunch and Learn. Today we are looking at delirium, dementia and depression. How do I know the difference? My name is Dr. Ellie Worthington. I'm a GP who works for Hammersmith and Fulham Training Hub. So why is this important? Well, dementia, delirium and depression can all coexist at the same time, but they are also clinically similar, which means that it can be difficult to tell them apart. And there are different ways that we need to approach and manage each of these 3 conditions. And therefore, it's really important that we're able to recognise and identify what's going on for somebody. And this can be, as you will see, very challenging for us who work across primary and community care in particular. So all of these conditions affect brain function. And just like much of medicine, life doesn't really fit into neat boxes where it's obvious that it's one thing as opposed to another. And as I mentioned, they can exist at the same time. So we know that depression in an adult life is an independent risk factor for developing dementia in later life, even though we're not quite sure why this is the case. We also know that having dementia increases your risk of depression and also delirium, and that having delirium means that you're more likely to go on to develop a dementia. And so all these 3 are often present together, and they can be hard to tell apart, which is why we're looking at this topic today. I did want to mention at the start that there are many other causes of confusion or altered brain function that we won't be covering today, but it is always important if we're starting at the beginning to think of other things that might be going on, perhaps if you've considered if someone might have had a stroke or a head injury, or have some kind of metabolic disorder, for example, problems with their sodium. These can also all present with some of the same symptoms. So part of our recognition process is also looking at what other causes might be going on. So the 2 learning objectives for today's session are that we would come away feeling more confident in, firstly, to recognise delirium, dementia and depression in older adults, but secondly, to distinguish between them, as I said, to help us to manage them better. I won't be able to cover within the time specific management for each conditions, but we may touch on a few things as we go. So one of the questions I want you to ask yourself is to think about what is it that all of these 3 have in common, as well as how are they different in terms of the way that they affect the brain, the demographic, so who they affect, the clinical picture, so how they present or what they might look like in a resident or a patient or a person that you know, and who is at particular risk of developing these 3. So we're going to take them in turn and start off with delirium. So this is defined as an acute confusional state and is technically a transient condition. So it comes on suddenly or acutely, and then oftentimes will resolve over the course of days or weeks. However, there is a chance that delirium may never completely go away or heal and can go on to a form of longer and ongoing cognitive impairment or lead to dementia. But for many people, and this may not be even older adults, but younger adults may get a delirium which comes and goes, and they go back to their normal brain function afterwards. So the main, it often comes on over 1 to 2 days. And one of the key features is a fluctuating course. So you'll see that somebody's confusional level comes and goes or goes up and down depending on the time of day. And it's as I said, it's potentially reversible. The 4 areas that delirium tends to affect are that firstly, it disturbs consciousness. Secondly, it disturbs function. So this is usually someone's mobility or their sleep pattern, or causes agitated behaviour. Thirdly, it can disturb perception. So you commonly see hallucinations in people with a delirium, whether they're hearing or visual, things that they wouldn't see otherwise. And fourthly, it can disturb social behaviour. And so you may find what seems like a personality change or a changing the way somebody can communicate, or their attitude, or their cooperation during delirium. And critically for us to remember is that there are two main ways that delirium tends to present. And these are called hypoactive delirium or hyperactive delirium. And that's really the distinction between the level of responsiveness and activity seen in those suffering from delirium. As you can imagine, those who are hypoactive tend to become much quieter, withdrawn, they might sleep more. And obviously, critically, this can mean that they're much easier to miss, particularly in acute hospital settings or in care homes, for example, because they're people who won't be shouting loudly, they won't be drawing attention to themselves. And so picking up on this can be much more subtle and therefore challenging. The hyperactive delirium, in contrast, tend to be affect people in a way that they might be much more agitated, much more verbally aggressive. Again, this is where the sleep pattern tends to be reversed. And this again can pose a real challenge in terms of caring for somebody who may be responding in this kind of way, restless and agitated. In terms of causes or triggers, there is always something that causes a delirium. And commonly things that we think about, particularly in the community, are infections such as urine infection or a chest infection. But even the flu or any kind of viral infection may bring with it an associated delirium. But there are many, many different causes apart from infections. So any severe or sudden medical problem like a heart attack or a stroke can also bring a delirium. Having severe pain can cause people to have delirium. Many of the drugs that our patients and residents are on can commonly bring on delirium, particularly some of the painkillers like morphine and OxyContin. Having imbalances in your electrolytes or your salts can cause delirium, dehydration, constipation. So as you can see, there's always some detective work that's needed if somebody's presenting in this acute confusional state to see whether there's an underlying cause for it. And part of the treatment of delirium is to treat the acute cause, and you would hope to see that impact on the brain recover in time. In terms of who gets it, we know that at any one time, about 1 to 2% of older adults in the community will be affected by delirium, and this goes up to 14% in the over 85s, and then much, much higher in acute settings, so on hospital wards or in nursing homes, up to 60% of people might be suffering from delirium. So clearly hospitalisation is a big trigger, as is increasing age. And in terms of prognosis, well, it is associated with poor outcomes. As I said before, it can lead to a permanent ongoing confusion. And even if it does resolve, it is a risk factor for developing cognitive impairment or dementia in the future. It can also be misdiagnosed as depression or dementia, and clearly that means that you might then miss treating the underlying cause. In terms of a screening tool that you might want to use in the community, there are several that have been developed, but this one is fairly straightforward and I think easy to use. So you're trying to look here for that. There are 4 areas to look for, and you're looking for number 1 and 2 plus either 3 and 4 to be present in order for you to suspect a delirium. So the first one here, and this is the nice guidelines recommend using this CAM or confusion assessment method. So the first one is the acute onset and fluctuating course. This should be relatively easily obtained from a collateral history. So asking a spouse or relative or carer whether this is sudden onset and whether the confusion level has been changing over time. The second thing is inattention. So you might spot this by somebody who seems to have difficulty focusing their attention. They may seem very easily distractible. They might not be able to keep track of what's being said. You can look for it formally by getting somebody to count backwards from 20 down to 1 to see whether they're able to sequence numbers. Or you could ask them to recite the months of the year backwards, and that would also test for the presence of inattention. The third aspect is disorganized thinking. So is the patient's conversation rambling or incoherent? Are they making sense? Are they following a flow of thought, or do their thoughts and conversations seem illogical? Do they switch rapidly from topic to topic? So these all might be signs of disordered thinking. And then fourthly and finally, is there an altered level of consciousness? So this is where they're either hyper alert, so in a hyperactive delirium, or hypoactive, so drowsy or difficult to rouse. And clearly if somebody's completely unconscious, you won't be able to assess the other three of these, and you need to call an ambulance. So moving on now to depression, so the second of our three conditions here. So depression is obviously a term that's probably understood by many. It's very common within our population, both old and young, sadly, and clearly has been a key area of concern since COVID-19, particularly as we know that mental health has been significantly affected by the effects of lockdown, particularly in all the restrictions on our social contact. But it can be difficult, I think, to actually pin down what is depression, what does it mean to have a depression, given that part of our human experience is that we have a range of emotions, including sadness, and people may feel anxious or hopeless at various points during their life. And so trying to figure out when is something actually a depression. And generally that's when something is significant enough or sustained enough to be impacting on the way that someone's able to live their daily lives. But a definition that I quite like is a disorder marked by great sadness, apprehension, feelings of worthlessness and guilt, withdrawal from others, loss of sleep, appetite and sexual desire, as well as loss of interest and pleasure in usual activities, and either lethargy or agitation. And even there you can see some of the overlap with delirium in terms of the lethargy and agitation. But again, NICE defines this as an affective disorder. So that is, it affects mood and emotions. So it's the felt part of our human life. And the three key features that we look for, particularly in a medical context, are persistent low mood, loss of interest or pleasure, and then fatigue or low energy. And then there are many other symptoms, some of which I read out that are commonly found. People's self-worth can be affected. They can carry a sense of guilt. It may impact their concentration. You may find the presence of suicidal thoughts, or not, although not necessarily. People can lack self-confidence and lack motivation to do their normal activities. So the things to note in terms of older adults and depression is that the biological symptoms tend to be more common in the over 65. So these are the things that affect physical symptoms like weight loss or loss of appetite, and then also affecting sleep. So not being able to get to sleep or waking in the night. And so that affects, again, some of the choice of antidepressants that we use for older adults to try and compensate some of those symptoms. And then another thing to note, just in line with how I started sharing about this in the context of COVID, but it is just important to remember that there are normal adjustment reactions. So any any grief or any loss, I should say, is meant to cause a sense of grief. If you think about particularly older adults, often as you age, there are significant losses associated with aging, whether that be loss of a loved one or spouses, or loss of independence, as you move through increasing frailty, perhaps loss of a home if you have to move into different kind of accommodation, might be loss of friends as your peers may also sadly pass away, or just a loss of all of the things that you used to be able to do, and the things that you loved, the people that you loved. And so it is natural actually to grieve loss. And so again, distinguishing between what we might consider a normal reaction to things being challenging, to something that counts as a depression, requires some careful thinking, and again I would say paying attention to the length of time that these feelings are sustained, as well as how severely and significantly they impact someone. A stress response syndrome, in contrast, usually would begin within 3 months of something stressful and usually resolve within 6 months. They tend to be less severe, they aren't associated with suicidal feelings and less biological symptoms. So that could be a way of helping you distinguish between something stressful or upsetting versus someone actually suffering from depression. And in terms of how common, well, in the over 65 population, it's thought around 22% of men and 28% of women suffer from depression. And it's also estimated that 85% of those over 65 who have depression receive no help from the NHS. So again, a startling statistic in my mind of the majority of people suffering from depression in older adults are living with it with absolutely no support, perhaps unaware themselves, or not knowing how to reach out. And so anyone working with older adults, even if someone doesn't have a formal diagnosis, we should be very mindful and alert to the possibility of a depression. It's thought that 40% of those in care homes might have depression, and nearly half, another 40% of those with dementia. So again, this sense of overlap between the syndromes. So in terms of screening, again, the NICE guidelines recommend these 2 questions. So these could be used by anyone who's interacting with a patient, whether you're in home care or whether you're a healthcare assistant, or whether you're a family member. But during the last month, have you often been feeling down, depressed, or hopeless? And secondly, during the last month, have you often been bothered by having little interest or pleasure in doing things? And if somebody answers yes to both of these, it's thought to be highly specific for depression, but not as sensitive. So this means that if somebody has depression and answers yes to these things, it probably is depression, but they may have depression but not necessarily answer yes to these. So it might miss some depressions, but if people do answer yes to both, then it likely will be depression that they're suffering from. And so obviously they need to be followed up and signposted on. I think it's helpful when we talk about dementia just to remember that it's a progressive and global assault on brain function and the executive functions of the brain. It's a horrible disease, and I think this picture on the right there of the shrunken brain on the right there of advanced Alzheimer's compared to a healthy brain is visually quite shocking, and a good reminder to us in terms of how much the brain's ability to function properly is going to be affected, particularly as the disease progresses. And again, just to remind us what kind of things happen to those suffering with dementia. Well, as is probably commonly known, it first affects short-term memory, whereas longer-term memories seem to be stored in different parts of the brain, and they tend to be retained. Personality can change, and this can be particularly in frontal lobe dementia, which affects the front part of the brain. Sequencing of tasks, so being able to follow through a series of tasks that are contained within something like making a cup of tea, for example. If you consider all of the steps that are required that go from knowing where the kitchen is, finding a clean cup, locating a tea bag, boiling the kettle, pouring hot water safely into a cup, adding any milk or sugar, stirring it, throwing away the tea bag. All of that is a series of steps, and so part of that sequencing is lost in Alzheimer's, which means people get stuck doing even familiar tasks. We know that language is affected, so people end up unable to understand what is being said, but also lose a lot of words. They lose part of the library of their vocabulary, and so they find it more difficult to express themselves. Judgment can be affected, so particularly the parietal lobe, which is at the side of our heads, helps us to judge distances, and if this is affected, then things like navigating stairs can be really challenging for people. Visuospatial awareness, so being aware of the surroundings, and for example, perception can be affected in terms of often something like a coloured rug on the floor can be mistaken for something else, and can cause a trip hazard or a fall hazard because they're not able to see it as a rug. It looks distorted in their minds. And then finally, and something I think is particularly relevant to when we consider dementia overlapping or coexisting with depression or even delirium, is the control of emotions, because you can often see emotional lability in those with Alzheimer's and other kinds of dementia. And emotions have a big influence on our memory. So highly emotional experiences are more likely to be stored in our long-term memory. And we're more likely to recall the emotional aspects of an experience. And yet the hippocampus, which is where new memories are formed, so is often affected first in the Alzheimer's process. So that's why the short-term memory is affected. And yet the amygdala, which is the part of the brain that helps store the emotional aspects of memories, is later affected in the trajectory. And so you may find people are able to remember emotion even though they couldn't tell you the actual factual recall of something. And so it can appear to an outsider that someone is just emotional when actually they are having they're remembering something that's linked to strong emotion for them. So finally, if we just compare the three conditions there, so we've covered each of them in turn, and sometimes it's helpful just to look at them in a kind of side-by-side way in this table, which I've taken from a paper, and I can give the reference for that at the end. But in terms of onset, delirium is the fastest, so you're looking at a change over hours to days, whereas depression would be weeks, and dementia months to years. In terms of the cause, as we said, delirium has multiple causes. Depression is to do with your neurotransmitters not working properly in the brain, and that's the basis for our treatment with medication actually. And then dementia, as I said, is a progressive brain disease. Duration, so delirium hopefully will resolve within weeks to months. Depression could be months or could become chronic and ongoing, and dementia is usually over years. In terms of the course, so delirium is potentially reversible. Depression could recover in months, or you can have relapses of depression. And then dementia is unfortunately irreversible. In terms of level of consciousness, so delirium, as I said, is the consciousness is usually changed, and you get either a hyper or a hypoactive form. Depression consciousness is usually normal. Sometimes it's slowed, and in dementia, it's normal as well. In terms of orientation, delirium, you get that acute confusion, as I mentioned, whereas in depression, orientation is usually intact. People usually know where they are in time and space. And in dementia, that becomes gradually impaired as people become disoriented. Thinking in delirium is disorganized or incoherent. In depression can be distorted or overly pessimistic or negative. And in dementia is impoverished. So a lack or a paucity of thought is sometimes, it's sometimes described as. Attention in delirium is hard to direct or sustain. In depression, you might find people have a difficulty focusing or concentrating, but in dementia is usually left intact. And then finally, sleeping and waking, often disrupted in delirium, can be disrupted in depression. And in dementia, it tends to be normal initially, but can become disrupted as the dementia progresses. So just some resources that I really recommend. There's a podcast about aging for MDTs called the Hearing Aid Podcast, which are hosted by some geriatricians in South London. And these have excellent talks that are very accessible to a wide range of healthcare professionals, social care professionals, that are very informative on any topic to do with aging. So I really recommend those. And then the British Geriatric Society also has tons of articles on all the aspects of aging. So those are some really good resources that I recommend. So we've come to the end of today, looking at delirium, dementia and depression in the older adult. How do I know? Hopefully that's been helpful. Please feel free to contact us at the Training Hub if you have any further questions. Thank you.